The talk is impossible to establish evidence-based practice with ECMO. This is a huge challenge. I don't think we're going to be able to do it in my lifetime, but what I'm going to focus on in this talk is actually more of VV COVID patients. So I think now the COVID patients are kind of a set population to where we can make adjustments in our ECMO practices. So you can read this. Basically, it's just, we use ECMO. According to ELSO, more than 100,000 patients have been put on ECMO. Gerald Myers gave, a really good talk on the progression of ECMO now with not only flu, but with COVID. It just exponentiated the amount of ECMOs that we have now. And hopefully with that survival rate that he showed of 63%, it's still going to be a viable option for post-cardiotomy and anybody with pulmonary problems. So we have different types of ECMO, VV ECMO, VA ECMO, and VAV ECMO or VVA ECMO. It just depends. The VAV ECMO is usually you're converting a VV ECMO that's pulmonary into a cardiac, or a cardiac needs then pulmonary support. And it depends on how if you want to decompress the heart and things, you might put a vent in. This is an example of that vital table out there that they had. This was, well, let me go back. The biggest reason that I wanted to kind of give this talk is because every institution I go to is different, okay? California uses these tables, and they've shown really good results with these tables. This gentleman is in a chair. We had to lift him up on ECMO and put him in a chair. The only reason, we did this because these patients' lungs were gone. They're shot. They're going to need a lung transplant. The only way to do that is to rehab them a little bit. These tilt tables are really nice for the rehab of atrophied muscles. But also, with the tilt tables, you can evacuate certain spots in the lungs. So in ECMO now, they roll them. They roll them on one side for a period of time, and then we go up on the table and down on the table, and we just try to, change the spaces in those lungs as well as help out their strength when they have to rehab after having a lung transplant. So that vital table was interesting because he said, I saw this in California, and I've seen it no place else, but he says that they can't keep up with the demand of these tables, and right now Florida, Texas, and California are big markets. But I think if we continue with this process with ECMO for the COVID patient, that this table is really important. So again, every place I go is different. So this is the new Nautilus oxygenator, but again, you would need a CMAG. So everybody uses a CardioHelp because it's nice because it has a motor and an oxygenator right there. But if you use something like the Nautilus, you're going to have to use CMAG or whatever you want to use to pump that fluid through. But again, this is changing. And then I saw this here at Indianapolis Franciscan Hospital, where not only did they use the Nautilus, and they seemed to think that the flow dynamics through the Nautilus was far superior, but at the same time, they introduced bivalve. They're very aggressive with bivalve, and they used the Cytozorb for the cytokine storm, and they gave Amicar on ECMO, which kind of blew my mind away. So they had nosebleeds or mouth bleeds and things like that, and they gave Amicar. Some places are using tranexamic acid. I think the Mayo Clinic has a protocol for that. But my goal is just to get everybody on board with using the same type of equipment. Maybe not the same type of equipment, but the same protocols, anticoagulation protocols. What are we going to do to rehab? The other significant thing that I've seen traveling with the COVID is sedation is incredible. I mean, these patients are on ECMO for months, but for part of that couple months, they're heavily sedated because once you unsedate them, their saturations fall so badly that they have to resedate them. And I think this is a trend. Every place I've gone that they've kept these patients under. So not only is our ECMO machine going to be important, but how they anesthetize the patient is also important, and the ventilator support from respiratory therapists is going to be really important because the overall goal of VV ECMO is to give the lungs time to rest. So, of course, ECMO has its risks. The most common is, of course, bleeding. John talked about anticoagulation protocols and the bleeding issues and fibrinolysis. You have surgical site bleeding, internal bleeding, and cranial bleeding. So a lot of these, we use these tests, ultrasounds, hematology, coag tests. We use whatever's available, chemistries to determine if we have acute a kidney injury, what direction we're heading with ECMO. We use a lot of these tests to determine where we're headed. Surgical complications, stroke, infection, blood clots, error, and then of course oxygenator failure. So ECMO selection, again, arterial blood gases, we use the chemistries, x-rays, echoes, we use wedge pressures, especially with our pulmonary patients. And then determination of, we can figure out the upper body's not being perfused properly. That's when you're maybe throwing another cannula and go from VVVA to VAV ECMO. So you have shunts, and then you have LV distension and LV failure. That's, again, we've seen LV distension that they'll throw into a VA circuit. They'll throw in a vent, and then it'll be a VAV. So it's important selection criteria as well. I mean, we talked about a little bit of that yesterday too. It's like we can't wait too long to put these patients on ECMO. We need to know exactly when to put them on ECMO. If we wait too long, it's not going to help the patient. We're not going to have success. So there's selection criteria for both the respiratory VV ECMO as well as the cardiac ECMO. I just highlighted some of the areas that maybe with the VV, now of course with the respiratory ECMO, it's going to be the COVID patients or the flu patients. Then VA ECMO could be, post-cardiotomy. It could be a number of reasons, but if the lungs fail, maybe the heart's going to fail or the heart's failing, and so you have multiple options now with ECMO, but you got to select the right patient population. So you have here absolute and relative, and then contraindications on which patients you don't want to have. Like right now, they're setting age limits on people that they put on ECMO, as well as ventilator days. Days on ECMO, usually after 7 days on a ventilator, they won't put them on ECMO. They try prone position and things like that. So I think just selecting the right patient is going to be helpful for our success as perfusionists and ECMO specialists. So just, of course, VV ECMO, the lungs fail for a number of reasons. Could be cancer, could be pulmonary edema, pulmonary embolism, sepsis, influenza, now COVID-19, neonatal issues. And usually it's, what leads to that is hypoxemia. They're not perfusing all the tissues properly, or excess CO2. Let's see. So it was found that this Zangrillo, he did a study on H1N1 patients, and he had a 72.5% success rate, which is pretty amazing. He had a certain population. I believe this was published in Australia. But H1N1 was kind of the first taste that we all got with ECMO outside of already existing pediatric ECMO, which we had for diaphragmatic hernias, post-cardiotomy, and things like that. So this is good news, because when I went to school, it was, cardiopulmonary support was basically 25% viable. And so I think now with all the tools that we're introducing during these conferences and stuff, we're increasing our percentage rate. But this just shows you that there's also trials out there where they're using monoclonal antibodies, and also the remdesivir that came up with Trump and everybody like that talking about remdesivir. I also believe that coming from the ER to the ICU before we even go on ECMO, we're better. Convalescent plasma maybe, or we're treating the patients better, because I met Mohammed in New Jersey when COVID, the outbreak happened, and it was far different than today. The patients seemed to be a little bit better before we put them on ECMO than back then, and they put on older patients at the time. So again, we're learning to base a selection criteria on these patients so we have success. Younger patients, just looking at their background, So there's some trials going on. So the COVID pandemic is here. It's still going on. Nobody's put a stop to it yet. And I think we're going to see that population more and more. Another, with the pandemics, we had outbreaks in the Middle East with the MERS and influenza A. I was at the University of Alabama, Birmingham. They had the most flu deaths in the country at the time, and they had 10 people on VV ECMO based on just the flu alone. And then when COVID happened, I thought the flu-COVID combination was going to be terrible. We were going to be overrun with ECMO patients, but actually I think wearing the mask and stuff cut down the flu has seriously decreased the amount of patients that we put on ECMO for flu, influenza. Let's see, so they have this, I don't know, my son set up this, but if you can click on this, the RSP score, I don't think I can do it here, but if you do that, this was produced by ELSO. It's Respiratory ECMO Survival Prediction Code. And it goes along with age. You know, if the patient has diabetes, we talked about diabetes, hypertension, things like that, that they have some pre-existing conditions. It gives you a number, and then it gives you, is there any way we can click on that? It gives you survival, and this is ELSO. I don't know if this is gonna work. My son has built his own supercomputer and things like that, so. But anyway, that scale will come up, and it'll give you, probably not. We can move on, I guess. But the idea is, again, the main goal of using these scores, these scales, and things like that is to get the proper patient to enable survival. No, I screwed the whole thing up, sorry. Phil, you want to take over from here?
You're doing great.
Come on, Phil. So anyway, selection criteria is important. And like I said, this talk is kind of going in the direction of just VV ECMO for COVID patients. And I think it's really important that we also, I'll show slides on anticoagulation. Everybody that's really outside of the box is using bivalve. So Indianapolis here, like I said, they use bivalve except for when they use cytazorb, then they use heparin, and then they switch back to bivalve. They used that Nautilus. They thought it had better flow dynamics. They didn't use the tilt table, but I saw that in California. So I'm thinking if we could get on the same page, like I said, that population, even though there's variability in hypercoagulability versus hypocoagulability, the population with the lung damage is the same, and we can, I think, get some evidence-based medicine to say this is how we should do it. How many people are still doing ACTs for ECMO? Anybody? So ACTs kind of went by the bedside because I said, the activated PTT is kind of more the gold standard now, but anti-10A would be awesome if your facility can do it and you have a quick turnover time. AT3 levels. Okay, back where we're at. Thank you, guys. I won't ask you to do that again, but if you go into look up RESP score on Google, and it'll come up and it'll show you, you can put in every category, like 18 to 35, and then they'll say, okay, that's a -1. And the bigger the number, the less survival. So all these indication, neurological deficit to begin with, things like that. It's a pretty neat scoring system. This is the graph, actually, RSP score and in-hospital survival rate. So as you can see, as the score goes from a -8 up to 8, mortality goes up. These are the hypoxemic chart. I think basically what, even with, here's the thing is we're supporting the patients on VV ECMO and at 100% and the ventilators at 100%. Still sometimes we don't have good oxygenation, and that's where we found heavy sedation work for quite a long period for some of these patients. They were heavily sedated for over a month before but every day they tried to do a trial, but every day they took the sedation off and then the saturations plummeted. So I think it's a matter of time when they're able to recover that saturation. So let's see, ECMO patients with COVID are associated with both respiratory and cardiac failure. About 25 to 30% of these COVID patients have cardiac issues as well and require the VA ECMO. Let's see, so resource-intensive therapy, that's I think John was talking about the hub and then the spokes in the hub, and then where I go, they ship people to Hershey, Pennsylvania, or wherever from these off sites, and that's good because we need a nice center that has all these multiple resources, because you're going to need surgeons, intensivists, anesthesiologists, nurses, physician assistants, nurse practitioners, respiratory therapists, ECMO specialists, and perfusionists all on board with this. And that's a labor-intensive demand for some of these institutions. So again, the myocardial environment is up to 20 to 30% in patients, with the 50 to 60% mortality when you start throwing in cardiac component to these otherwise respiratory ECMO patients. Let's see, ECMO may be required on ongoing renal. So renal replacement is not a counterindication as well, and a lot of the patients, like we talked about, require renal replacement based on low cardiac output or whatever. Here's a management strategy I took from Budak. Basically, you need, I can't really even read that, it's kind of blurry, but you need all these things. Down in the middle is that cytazor, but you need monitoring, you need protective PPE, you need all kinds of things to just get involved with ECMO. Proper monitoring. They were talking about the NIRS earlier. We use NIRS on both legs and the head as well, because even though they have that distal perfusion cannula now, still sometimes you can lose a leg or not perfuse that lower leg properly. Of course, oxygenator, blood products, extensive blood products. So your institution needs to be able to take this on. COVID complications, again, coagulation abnormalities with thrombotic events. You have then what I've seen is the refractory hypoxemia, which I talked about. Is really just, unless they're sedated, we're not going to be able to oxygenate these patients. And to say that too, I don't have a lot of, I do have a lot of pediatric ECMO experience, but since I'm more of in the OR perfusionist, but I have gone to these other institutions to watch ECMO, so by no means am I ECMO specialist or as much knowledge as some have. Who's laughing? So in this ELSO, it said in 2020 they had 813 patients with COVID were managed by ECMO. That's a fairly increased amount probably from the previous years. Flu probably rates up there pretty high as well. But I didn't get all the numbers when the numbers didn't all work out when I saw this from ELSO. But anyway, we're trying to decrease mortality rate every day. Because like I said, when I went to school, it was 25% survival. More cardiac than respiratory, and the kids always had like a 70% survival with the VV type ECMO, diaphragmatic hernias or whatever. So we knew that we could get to that point. We still can get to that point. Let's see, anticoagulation, can you use ECMO bleeding algorithms? I know at Mayo Clinic they have, like if they have blood loss less than 2 milligrams per kilo per hour, then they'll start they'll do heparin. So that's the other thing, is everybody's protocols are different. How long do you wait till after cannulation? You give that big bolus, and then how long do you start your heparin? Of course, you need to get your values, activated PTT, and some folks still use ACT, to determine where we're at before we start these anticoagulation protocols. And they'll start here. This is just a range heparin, 5 units per kilogram per hour, and then bival. Depending on renal function, bival it can be anywhere from 0.4 to up to 0.03. And then with fibrinolysis, we can, that's going on. We have little clots in the oxygenator and things like that. We know we have clots. We know we have fibrinolysis. You can use the tag and look at D-dimer elevation for that. You can give FFP Like I said, I was really surprised. I spelled that wrong, Amicar, or my son spelled that wrong, Amicar. And then transexamic acid, which I was outside of the box for me. I've never seen, a person that's anticoagulated that you give Amicar or transexamic acid. So let's see, bleeding strategies described to prevent further hemorrhage in the patients. So fresh frozen plasma, vitamin K, A-protein is no longer available. In recombinant factor 7. Bleeding on ECMO can be exacerbated by fibrinolysis, which also John covered really well. And it's a naturally occurring process where you have clot, you're going to have clot breakdown. And you have both primary and secondary fibrinolysis. And so, like I said, Amicar and transexamic has been used. Again, every place from every institution is different, what they're going to use. And I would like to see everybody kind of get on board with that. So heparin, let's see, ACT, you can use the anti-10A from our PharmD. Gave a really good talk on that, and I didn't know that anti-10A was really that specific for heparin. AT3 levels, and then the R value on a tag. Now, the activated PTT goals within the first 24 hours, this changes from institution to institution as well, but it could be 40 to 60, and then they step it up. So it depends. They have orders. The nurses have orders. What I found is pretty interesting too is they do have now an algorithm at some hospitals. They'll say, hey, my activated PTT is too high. We stop, bivalve or whatever they're using, and give it an hour, and then they will come back 20% less of that dosage, 20% less, and then start it up again. So they have a little algorithm that says, hey, what I need to drop this dose to. It's pretty neat. So bivalve is a synthetic inhibitor of thrombin. John talked a little bit about that. It's a direct, so it's a direct inhibitor is DTI, sometimes it's abbreviated. Its half-life is only 25 minutes. With normal renal function, again, the bivalve dosage has to be changed based on kidney function, creatinine clearance. And there's some nice charts from ELSO as well as when a creatinine clearance gets so high that the dosage of bivalve that should be used. So hopefully everybody's pharmacist is involved in this dosing protocol. I know as a perfusionist that I'm probably more of a hematologist than the hem-onc guys that come in, because the hem-onc guys only know oncology, they don't really know hematology. And so we're kind of pseudo professionals on anticoagulation, whether we like it or not. So yeah, that slide down here. So they have, like I said, titration tables and the stepwise escalation of dosage never to exceed 20% of the previous dosage. This is for bivalve. And if this is super maximal, then like I said, they'll discontinue for an hour and then restart again at 20% lower bivalve dosage. Transexamic acid, I don't know, I guess with questions, Phil, I know that they use this at Mayo. I saw it in their protocol. And what's really nice about the Mayo Clinic in Rochester, they also have the Florida and Arizona ones, and they have protocols for all these things, decannulation, everything. And I think every big institution that handles ECMO and stuff should have these similar protocols. Let's see. Okay. Again, dosing schemes and targets. Let's see. Moving on, then Amicar is a lysine analog effective in certain bleeding disorders due to its inhibitory effect of plasmin. So Amicar and transexamic acid has different targets. One protocol used 5-gram bolus over 1 hour, followed by 1 gram per hour for 15 hours. And again, this was, when I saw this, I was kind of amazed because we wouldn't think about doing that in the OR while on bypass. And they're giving these, while they're giving an anticoagulant, they're also giving these fibrinolytic agents to reduce fibrinolysis, which is pretty interesting. And they did that again for nosebleeds, throat bleeds, cannula, oozing at cannula sites. and it's been shown to be effective. And so, in conclusion, you need the resources. You definitely need good patient selection and quick determination on how quickly you're going to go on ECMO instead of waiting for this person sitting on these patients. Anticoagulation protocols you're going to have down, and then all the tools, proper diagnostics, like we talked about. If you're going to use heparin, an anti-10A assay would be really nice to have available in your laboratory. And then, again, develop guidelines for both ventilation, sedation, and coagulation again. I'd like to thank you. Again, I'm not an ECMO specialist, but I dabble. So Phil, how many questions do you have?